Today we're going to continue with the lecture on the blood vessels, looking at the pressure in the blood vessels. So to really understand blood pressure, you do have to look at things both in the heart and with the blood vessels, since both of them are going to play a part in it. Your pulse pressure is the difference between the systolic and diastolic pressure. So remember, systolic pressure is the pressure when the heart is contracting, and diastolic is the pressure when the heart's relaxing. So your mean arterial pressure is going to be the steady component of the blood pressure. The way that we can calculate this is taking your diastolic pressure plus 1/3 of the systolic minus the diastolic pressure. So an equation that would summarize this would be your mean arterial pressure is dP plus 1/3 of your pulse pressure. The healthy blood pressure is about 120/80 millimeters of mercury. Hypertension is considered anything above 140/90 millimeters of mercury, although clinically it's not unusual to see it being addressed when it's lower than that. And then hypotension is anything below 90/60 millimeters of mercury. There are times when it is considered normal in a person if their blood pressure is a little bit below that. So you may see that in some high-end athletes. With the hypertension, it's typically diagnosed if it's elevated on 3 separate occasions. We don't necessarily want to treat it if it's on one occasion, because there are times when it's absolutely appropriate for the blood pressure to be a little bit higher. So again, with these notes, there are several different diagrams and pictures in here that are going to be a little bit repetitive, but the reason for that is some pictures seem to click better with some people than others, so use the ones you like and you can ignore the other ones. So this picture here is going to show what is going on at the arterial end of a capillary and at the venous end of a capillary, and you can see the factors that are going to drive fluid in and out. So the cardiovascular system excuse me, will put blood plasma in through the middle of the vessels. So you can see the blood hydrostatic pressure here is about 35 millimeters of mercury pushing out. The interstitial fluid hydrostatic pressure is 0, or about 0 millimeters of mercury pushing in. So you're going to have movement going out here because the fluid will go from the area of high pressure to low pressure. When you look here on the venous end, you can see the difference in here. So if you're looking at the interstitial fluid osmotic pressure, it's only about 1. The blood colloidal osmotic pressure is about 26. So it's going to help fluid go back into the veins at this point. So the colloidal osmotic pressure is going to be the osmotic pressure that's exerted by large molecules. These large molecules are going to help hold water within the vascular space. So this will be created by plasma proteins like albumin, is going to be one of the main ones that do this. So they don't readily cross the capillary membrane. Osmosis is diffusion across the permeable membrane, and osmotic pressure is the result of that diffusion across the permeable membrane. So your net filtration pressure is the balance of 2 pressures. So you have 2 pressures that are going to promote filtration and 2 pressures that are going to promote reabsorption. So the ones that are going to promote filtration, your blood hydrostatic pressure, this is generated by the pumping action of the heart, and it falls over the capillary bed from 13 to 16 millimeters of mercury as it moves through. The interstitial fluid osmotic pressure is about 1 millimeter of mercury. The pressures promoting absorption are going to be your blood colloid osmotic pressure. That's going to promote reabsorption because the blood plasma proteins are too large to cross the wall, so it's going to pull water in to dilute them. It averages about 36 millimeters of mercury. your interstitial fluid hydrostatic pressure is close to 0. So again, this is just reviewing that picture from above. Edema occurs when the capillaries are going to leak fluid and it starts to build up in surrounding tissues. So this can lead to swelling. Some causes of this include being sedentary, particularly for long periods of time. Hormones can influence this, particularly ones during pregnancy or the menstrual cycle. Sodium can influence this. Certain drugs like the NSAIDs and steroids, blood pressure medications, and diabetic medications can influence that. So we have Starling's law of the capillaries. So you'll remember before we had Starling's law of the heart. He has one of the capillaries too. So the volume of the fluid and the solutes reabsorbed is almost as large as the volume that's filtered. So on average, about 85% of the fluid that is filtered gets reabsorbed. The excess is going to enter the lymphatic capillaries, and this ends up being about 3 liters a day, and it will eventually be returned to the blood as well. So when we look at principles of blood flow, the blood supply to a tissue can be expressed in terms of flow and perfusion. Blood flow is the amount of blood flowing through an organ, tissue, or blood vessel in a given time. So we would express that in milliliters per minute. Perfusion is the flow in a given volume or a mass of tissue in a given time. So that would be expressed in milliliters per minute per gram. So at rest, the total flow is quite constant and is about equal to the cardiac output, about 5.25 liters per minute. The volume of blood that circulates through the system or the pulmonary circuit in the blood vessels each minute is going to be important for determining the delivery of nutrients, oxygen, and then the removal of metabolic wastes. So the more blood flow you have, the more of the nutrients you can deliver, the more waste you can haul away. If you remember back with the heart, when we looked at cardiac output, it's a function of the heart rate times the stroke volume. The distribution of where that cardiac output ends up depends on the pressure differences that drive blood through the tissue. It's going to go from the area of higher pressure to lower pressure. The resistance to blood flow in specific vessels will also influence this. Higher resistance is going to mean smaller blood flow. So the flow is proportional to the difference in pressure divided by the resistance. So the greater the pressure difference between 2 points, the greater the flow. The greater the resistance, the less the flow. So looking at blood pressure, contraction of the ventricles is going to generate the blood pressure. So your systolic pressure will be the highest. This is going to occur when the arteries are in systole, from the heart being in systole. Diastolic pressure is going to be the lowest arterial pressure, and that occurs during diastole. So the pressure is going to fall progressively as the distance increases away from the left ventricle. High blood pressure is also going to depend on the total volume of the blood. So it's higher in arteries and then lower in capillaries and veins, which is necessary because they have thinner walls. So this graph here is going to show you the pressure here in starting with the aorta into the arteries, and then when you get here to the arterioles, it starts to fall as you move through the capillaries and continues to decrease until you get into the veins in the vena cava. Vascular resistance is the opposition of blood flow due to friction between the blood and the vessel walls. This is going to depend on a few different things. The size of the lumen. So vasoconstriction makes the lumen smaller, and that's going to increase the resistance. So if you think of a real life example, imagine you're drinking through one of those coffee stirring straws that are really skinny. It takes more pressure to draw the fluid up through one of those than it does a regular straw. Blood viscosity looks at the ratio of the plasma and proteins to the red blood cell concentration. So higher viscosity is going to mean higher resistance. For this, if you think of honey versus water, how much resistance honey has to flowing versus water. Honey is more viscous. And then the total blood vessel length. So the resistance is directly proportional to the length of the vessels. So different sources have different numbers for this out there. So one source says there's 400 additional miles of blood vessels and 2.2 pounds of fat. So that would have to include capillary beds in there to get that distance. Other sources will say 1 pound of fat has about 1 mile. In any case, when you think about it, the longer the vessel is, the more it's going to increase the pressure. At some point as a kid, you may have had a drink that you set the drink on the floor and you were able to help yourself to a few different straws. So you linked those straws together and you stood up and you were like, I'm going to drink standing here while my drink is on the floor. And you attempted to drink through that really long straw and found the pressure was really hard. So that extra vessel length can have a huge impact on blood pressure. So weight loss can be a way to really be helpful in lowering blood pressure in a person, because you would get rid of all those extra blood vessels along with the fat. So venous return, that's the volume of blood flow going back to the heart through the systemic veins. So this is due to the pressure that's generated by the left ventricle. So there is a pressure gradient, and the blood pressure is the most important force in venous return. There's 7 to 13 millimeters of venous pressure moving towards the heart. In the venules, the pressure is a little bit higher. It's 12 to 18. And then the central venous pressure, where the vena cava enters the heart, is about 5. So when you look at draining blood flow from the head, gravity is going to help with that, as long as you are upright. The skeletal muscle pump is going to work in the limbs. So we can see it here. It's sometimes been referred to as the pedal pump. When you've got this vein here in the calf, when the calf muscles contract, it's going to squeeze and put pressure on the vein to push the blood up. When you relax, the blood can start to go down again, but you've got valves that's going to prevent the backflow. So that rhythmic contraction of the calf as you're walking around helps to keep the fluid pumped out of the legs. So it would be a similar mechanism in the arms as well. The thoracic or respiratory pump is going to do the same thing, except instead of relying on muscles, when you inhale, the thoracic cavity is going to expand and thoracic pressure decreases. The abdominal pressure will increase, and that's going to force the blood upward. In the legs, you can end up with varicosities if a person is not moving around for a long period of time and the blood starts to pool in there. It's generally not a problem with the respiratory pump, just because you're not alive long enough if you stop breathing for very long for it to get to be a problem. So the pressure will fluctuate between 2 to 6 millimeters of mercury, 2 on inhalation, 6 on exhalation. The blood is going to flow faster with inhalation. And then there's a little bit of cardiac suction from the expanding atrial space that will help to draw blood back to the heart as well. So this diagram shows things here that are going to increase the cardiac output aspect. So heart rate and stroke volume, things that affect stroke volume, sympathetic stimulation, increased venous return, things that will affect heart rate, decreased parasympathetic impulses, as well as the sympathetics, things that increase the venous return, increased blood volume, skeletal muscle pump, respiratory pump, and vasoconstriction. So then we can look at things that would affect the systemic vascular resistance. So this would be the blood vessel radius, so your vasoconstriction, blood vessel length, and blood viscosity. So blood viscosity, that can be influenced by the number of red blood cells, and blood vessel length by body size, such as obesity. So this here shows the velocity of blood compared to the cross-sectional area of the vessel. So with the aorta, arteries, arterioles, your larger vessels, as they increase in size, here you're going to have the velocity of the blood coming down as your blood vessel, or as your blood vessels decrease in size, the velocity of the blood is going to come down. So with your cross-sectional area here, the capillaries are actually going to be really high because you have so many capillaries. So things that are going to control the blood pressure and blood flow, you have an interconnected negative feedback system that's going to control the blood pressure. It's going to adjust heart rate, stroke volume, and vascular resistance, as well as the blood volume. So all of these things are going to come into play to help make sure you've got adequate pressure. Some are going to act faster than others. Some are shorter or longer term. So the mechanisms of this, you can have neural mechanisms, endocrine mechanisms, and autoregulation. Your cardiovascular center and the medulla oblongata is going to be really helpful in regulating heart rate and stroke volume. It's going to control the neural, hormonal, and local negative feedback systems that are going to regulate this. It can help control blood flow to specific tissues. So there are groups of neurons that will regulate your heart rate, the contractility of the ventricles, as well as the vessel diameter. Inside of there, you've got cardiostimulatory and cardioinhibitory centers inside of the cardiac center itself. The vasomotor control center will also control blood vessel diameter. It can do this through vasoconstriction with the adrenergic release of norepinephrine, or you can have vasodilation through direct or indirect release of nitric oxide. The cardiovascular center is going to have input come from both the higher brain regions as well as sensory adapters. So what's going on in the head as well as the body is going to influence this. We have baroreceptors that are going to monitor stretch, and we have atrial baroreceptors that are going to monitor blood pressure. The chemoreceptors are going to monitor carbon dioxide, oxygen, and pH levels. So your output from the cardiovascular center is going to flow along your autonomic nervous system. And then you can have the stimulatory effect from the sympathetics or the inhibitory effect from the parasympathetics. So input to the cardiovascular center, higher brain, proprioceptors, they're going to tell you if you're moving around, baroreceptors from the pressure, as well as the chemoreceptors. So those are going to send information into the cardiovascular center. What's going to go out is it can go through the vagus nerve to give parasympathetics to decrease the heart rate. It can go out through the cardiac accelerator nerve to deliver a sympathetic message. That will increase the rate and contractility. And then the vasomotor nerves are sympathetic. They'll constrict the blood vessels. So for the neural regulation, we have negative feedback loops from two types of reflexes. The baroreceptor reflexes, they're going to be pressure sensitive. They're going to be in the internal carotid arteries and the other large arteries in the neck and chest. The idea here is the body wants to make sure you've got adequate blood flow to the head. So the carotid sinus reflex helps with the pressure to the brain, and the aortic reflex is going to make sure there's adequate systemic blood pressure. So when the blood pressure falls, those baroreceptors stretch less, and you'll have a slower rate of impulses that are going to go to the cardiovascular center and end up decreasing the parasympathetic stimulation and increasing sympathetic stimulation. The chemoreceptors, they're close to those baroreceptors in the carotid sinus and the aortic arch. So they're your carotid and aortic bodies. They're going to detect hypoxia, hypercapnia, and acidosis, and then send signals to the cardiovascular center to increase the sympathetic stimulation to the arterioles and veins. That will lead to vasoconstriction and increase the blood pressure. The receptors are also going to give input to the respiratory center so you can adjust breathing and the respiratory rate along with it. So it does have a tie-in with the respiratory system. This just shows the anatomy of where these carotid bodies are in the aortic bodies and the different blood vessels coming out of the heart. So this is showing again some of the homeostatic responses. So if your homeostasis has been disturbed and the blood pressure rises above normal, you have the reflex response that's going to go to the cardiac accelerator centers and inhibit them. The cardioinhibitory centers will be stimulated. That's going to decrease the cardiac output. And then the vasomotor centers are going to lead to vasodilation to help lower blood pressure. So if the blood pressure falls below normal, you've got vasomotor centers that are going to lead to vasoconstriction to increase the blood pressure. And then the cardioinhibitory centers get inhibited and the cardioacceleratory centers get stimulated. This is going to increase the cardiac output out of the heart. So this is another way of looking at that picture here. So if you've got homeostasis disturbed here, you've had decreased pH and oxygen levels, high CO2 levels, you're going to have the respiratory centers get stimulated to increase the respiratory rate. That will affect the pH, oxygen levels, and carbon dioxide levels. And then you also have the cardioaccelerator center, the cardioinhibitory center, and vasomotor centers that are going to make their adjustments to increase the cardiac output as well as vasoconstriction. So this is another diagram here showing that if you have something that is going to disrupt homeostasis to decrease the blood pressure, the baroreceptors are going to be stretched less. It's going to let the control center and the cardiovascular center know, and it's going to go out to increase the sympathetic stimulation, secretion of epinephrine and norepinephrine, to increase the stroke volume, heart rate for the cardiac output, and constrict the blood volume to help return the blood pressure back to normal and balance homeostasis. So the hormones can regulate this as well. First one we have is the RAA system, or renin-angiotensin-aldosterone. Renin's going to be released by the kidney when the blood volume falls or blood pressure's down. And then angiotensin converting enzyme is going to act on its substrate to make angiotensin II. This will raise the blood pressure by vasoconstriction and lead to the secretion of aldosterone that's going to help increase water reabsorption in the kidneys. When you increase the blood volume from that liquid, you're going to increase the pressure. Epinephrine and norepinephrine, you can have the adrenal medulla release these in response to sympathetic stimulation or stress. It's going to increase your cardiac output by increasing both heart rate and contraction force. Antidiuretic hormone, ADH or vasopressin. This is going to come from the hypothalamus and be released by the posterior pituitary. This is going to be in response to dehydration or decreased blood volume. It's going to cause vasoconstriction to help raise the blood pressure. And then we've got one hormone here that will lower things, the atrial natriuretic peptide. This is going to be released by the atria of the heart. It will lower the blood pressure and cause vasodilation. And it will also promote the loss of salt and water in the urine to reduce the blood volume. So even though you do have a hormone that brings things down, typically that's not going to kick in unless the pressure is really high. We have lots of mechanisms to make sure blood pressure stays high enough, because it's critical you have adequate blood flow to the brain to stay conscious. So again, some more pictures here helping to illustrate things. So if homeostasis is disturbed, you've got decreased blood pressure. You can have EPO released from the kidneys for more red blood cells to be produced, activate the RAA system, the sympathetics. This is going to help make more red blood cells, make you thirsty. Aldosterone is stimulated, ADH to help hold in water, and increase the cardiac output. All of these things are going to increase the blood volume and the blood pressure. Likewise, if the blood pressure and volume is too high, atrial natriuretic peptide is going to help you excrete sodium in the urine, as well as other water loss, reduce thirst. It'll block the ADH, aldosterone, epinephrine, and norepinephrine. This is going to reduce blood volume and blood pressure, as well as with the peripheral vasodilation. So autoregulation within the tissue, we have local vasodilators that can accelerate blood flow, and these will act in response to various different things. So if you have low oxygen levels in the tissue or high carbon dioxide levels, that will influence this. If you've generated lactic acid, it will influence it. The release of nitric acid, rising potassium levels or hydrogen ion from the becoming more acidic in the interstitial fluid, local inflammation, and elevated temperature. So we have two main types of stimuli, physical and chemical. Physical things would be something like temperature changing. When you have warming, it will lead to vasodilation. This is going to put blood closer to the surface of the skin to allow it to cool. When there's cooling, you'll have vasoconstriction. So if you think about it, maybe you've gone someplace, you rode there, nice long ride in a warm car, and you get out of the car and step outside into the cold, and within a few minutes you have to go to the bathroom. Very inconvenient, but what's happened is your body has constricted the blood flow, pulled it away, and now you need to displace some of that fluid, and the way to do that is through your urine. So the myogenic response, the arterial is going to contract more forcefully when it's stretched. So we can have chemicals that are going to influence this. They'll alter the blood vessel diameter. These can be released by blood cells, platelets, smooth muscle, macrophages, and the endothelial cells. They can release vasoactive chemicals. So vasodilation can be triggered with potassium, hydrogen ion, lactic acid, ATP, nitric oxide, kinins, and histamine. Vasoconstriction can happen from thromboxane A2, superoxide, serotonin, and the endothelins. So for that autoregulation of blood pressure, two main types of stimuli. Physical, these would be the temperature changes, so causing the vasodilation or vasoconstriction, and then the myogenic response, where the arterial is going to contract more forcefully when it's stretched. The other type of stimuli would be chemical, and these will alter blood vessel diameter. White blood cells, platelets, smooth muscle, macrophages, endothelial cells, they're all going to release vasoactive chemicals. You can have vasodilation with the potassium, hydrogen ion, lactic acid, ATP, nitric oxide, and tissue injury. Those can release kinins and histamine. And then vasoconstriction can come from thromboxane A2, superoxide radicals, serotonin from the platelets, and the endothelins from the endothelial cells. So when we look at the circulation, there's an important difference between the pulmonary and systemic circulation when we look at the autoregulatory response. So your systemic blood vessel walls are going to dilate in response to low oxygen. Their goal is to increase the oxygen delivery. The walls of the pulmonary blood vessels are going to constrict under low oxygen. This is to ensure the blood flows better to the ventilated areas of the lung. With the circulation to the brain, we've got 4 arteries that have anastomoses. These anastomoses are really important to help ensure that we've got constant blood flow to the various areas of the brain. In the heart, you've got the coronary arteries that are going to come off of the ascending aorta. So with circulatory shock, this occurs when there's a dramatic loss in blood pressure or a sudden decrease in circulatory flow. So there's a few different types. Hypovolemic shock is sometimes going to be from acute hemorrhage. Other sudden fluid losses can do this, such as a lot of vomiting or diarrhea. With vascular shock, you have a loss of the vasomotor tone. This is going to result from anaphylaxis, and that's the reason why epinephrine is given during anaphylaxis, is to try and counter this. So you can have neural malfunction lead to this, or as well as certain poisons like being septicemic. With cardiogenic shock, it's a loss of cardiac output due to heart failure. So this picture here tries to show you what happens during hypovolemic shock. So you have the blood volume and blood pressure that are going to send information to the baroreceptors in the kidneys, as well as the aorta and carotid sinus. So when things are low, it's going to increase the secretion of renin. That'll lead to the angiotensin in the bloodstream. It's also going to lead to the adrenal cortex releasing some aldosterone. The hypothalamus and posterior pituitary are going to release the ADH. And the cardiovascular center in the medulla oblongata is going to increase the sympathetic stimulation and stimulation to the adrenal hormones. So these things are going to end up increasing the blood volume, the vascular resistance, and the blood pressure to help return the body to homeostasis. Signs and symptoms of shock. So the systolic pressure will be less than 90 beats per minute, or 90 millimeters of mercury. However, the heart rate is going to be rapid. So you'll have a weak, rapid pulse. The skin will tend to be cool, pale, and clammy. The person may have an altered mental state, which means they are not necessarily going to be able to help themselves in this situation. Urine output would be reduced. They may be thirsty. The pH would be low, and they may have some nausea. These pictures just show some anatomy of blood vessels. So you can see here you've got arteries that are going to go out to a location such as the arm, and then you're going to have veins that are going to return from that location and come back to the heart. So you do that throughout the body. It's not one continuous loop, but you go to a location and back. This diagram is good for illustrating this. So you can see that you would have something come from the left ventricle. So let's say you're looking at it going into your common iliac artery here. And then it's going to go into a capillary bed, and then it's going to return back to the heart through the internal iliac vein. So it does the same thing all over the body, that it's going to go out through an artery and back through a vein. So typically the blood flow is going to go to one location and back, but we do have a couple times where we make a second stop. So one example is the hepatic portal system. So remember, a portal system is going to transfer venous blood from one capillary bed to another, so it's going to have a second capillary bed stop, and then it will be returned to the heart. So the hepatic portal system is going to collect venous blood from your 5 abdominal organs, and it's going to send it to the liver so that it can process it. This is a good thing. When you're going to take in a toxin, most likely it's going to come in through those abdominal organs. This will allow them to go directly to the liver to get processed rather than spreading them out throughout the body. So some toxins that could come in through the stomach would be something like ethanol. In the small intestine, you would have some toxins, but also some nutrients that may need to go through here, as well as in the large intestine. With the pancreas, you've got insulin and glucagon that are going to get released. And then with the spleen, you would break down red blood cell products. The circle of Willis is important in the brain. This is the junction of the arteries at the base of the brain that encircles the middle area. So you've got multiple anastomoses here that's going to help to ensure blood flow. So you'll have left and right internal carotid arteries that are going to come in. You're going to have left and right anterior cerebral arteries, left and right posterior cerebral arteries, left and right posterior communicating arteries, basilar artery, and an anterior communicating artery. So you can see here the basilar artery. This is going to be the vertebral artery, posterior, inferior. So here you can see where you've got these communicating arteries, an anterior and a posterior communicating arteries. So this here forms a circle. So the fetal circulation, the umbilical veins are going to bring oxygen and nutrients from the placenta to the liver and then to the heart of the fetus. This is different than an adult. An adult's going to get their oxygen from the lungs. The fetus is going to get oxygen from the mother through the umbilical cord. So the ductus venosus bypasses the liver. There's 3 right to left shunts, and you're going to do this because oxygenated blood comes from the placenta, so you don't need to get oxygen from the lungs. The ductus arteriosus, you have the remnant ligamentum arteriosum. This is a vessel that's going to connect the 2 major arteries from the aorta and pulmonary artery so that they can carry blood away from the heart. The foramen ovale, it has the fossa ovalis as a remnant. It's going to connect the right and left atria, and this will close up by 6 to 12 months. So your typical umbilical cord is going to have 2 arteries and 1 vein. The vein carries oxygen and nutrients to the baby. The arteries are going to remove waste products. So umbilical arteries carry deoxygenated fetal blood towards the placenta to get replenished. The umbilical vein is going to carry newly oxygenated and nutrient-rich blood back to the fetus. So one of the things you will want to be able to do, I believe you're going to have to do this in the lab, is to map out the flow of blood. So this is showing blood flow for a fetus here in this picture. So this is going to show here where you have the placenta, and you're going to have the oxygenated blood coming in to the fetus here. So it's going to come in when it gets to the heart. The heart is going to push it around. So remember, you don't have oxygen happening in the lungs in the fetus, which makes it a little bit different. But you can see there is a huge amount of vascular tissue on the placenta. So that is the end of the notes for the blood vessels.